Magandang araw po sa lahat. I am Dr. Maria Rosario Sevilla, and today we will continue our discussion on the evolution of heart disease. If you recall, we talked about how the identified significant risk factors, namely hypertension, diabetes, dyslipidemia, obesity, and smoking, contribute to the development of atherosclerosis, which is the condition where fatty lesions or plaques form on the inside surface of intermediate and large sized arteries of the human body. We also talked about the role of platelets in the formation of blood clots, which contribute to the obstruction of the arteries. If this process occurs in the arteries of the heart, then we have coronary artery disease. Worsening disease in the coronaries cause the decrease in blood supply to the heart, leading to ischemia and eventual heart attack or myocardial infarction if it is not treated early enough. However, a patient does not need to have a severe heart attack to develop the complications of chronic coronary syndrome, which is end stage heart failure and the development of heart irregularities which can precipitate or cause sudden death. Both arrhythmia and heart failure arise from a severely compromised heart, and both ideally could have been prevented if the patient was diagnosed and treated early enough. This entails early detection and maximal control of risk factors, which can delay or prevent the progression of atherosclerosis, which will in turn decrease the risk for the development of myocardial ischemia and chronic coronary artery disease. Now let's talk about heart failure. Heart failure exists when the heart cannot provide the blood supply that is required by all the parts of the body. Remember that the heart has to push blood to all the distant points of the body, from the tip of your nose to the tips of your toes. Failure to meet the demands of the body ultimately leads to the manifestation of heart failure symptoms. Patients with heart failure can have a variety of complaints. These can range from mere weakness or lack of energy to the symptoms of advanced heart failure, which include shortness of breath, swelling of the feet and legs, difficulty of sleeping due to breathing problems, and having a swollen abdomen. Others will simply manifest with confusion and memory problems due to the lack of circulation in the brain. If the blood pools in the lungs, then coughing out frothy pinkish sputum is a sure sign of advanced heart failure. This is the 1994 New York Heart Association classification of the functional status of heart failure patients. It serves as code or a shortcut among doctors so that they can easily convey what the patient can do without wasting a lot of words. Most important to remember is that a patient in class 1 failure is completely functional and can do ordinary physical activity, while the patient in class 4 failure is incapable of engaging in any type of activity without becoming breathless and uncomfortable. In 2013, the American College of Cardiology Foundation and American Heart Association came up with the stages of heart failure. Stage A exists when the patient develops a condition that puts him or her at risk for the development of heart failure. These conditions would include uncontrolled hypertension, dyslipidemia, or diabetes. Stage B starts when the patient develops evidence of structural heart disease, such as the development of hypertrophy or wall thickening, wall motion abnormalities, or early onset of plaques in the coronary arteries. The patient will still be functional and asymptomatic at this point. Stage C is when the patient with structural heart disease starts to develop symptoms of heart failure, such as breathlessness or easy fatigability. This is where the functional classification from 1 to 4 becomes relevant. While stage D is when the heart failure is considered refractory or no longer responsive to medications and may require special interventions such as the implantation of automatic defibrillators, even heart transplantation. Heart failure is also defined based on the heart's ability to pump out the blood. This is measured by the computation of ejection fraction. Remember, ejection fraction is the percentage of blood volume pumped out by the heart with each contraction. Normal ejection fraction is 50% or more. So if the patient presents with symptoms of heart failure, but the ejection fraction is normal, then that is HFpEF or heart failure with preserved ejection fraction. If the EF is between 41 and 49%, then that is heart failure with mildly reduced ejection fraction, while HFrEF or heart failure with reduced ejection fraction is the label for a symptomatic patient whose EF is 40% or below. This is the diagnostic algorithm recommended by the 2021 ESC guidelines for the diagnosis and treatment of acute and chronic heart failure. As you can see, once you suspect the presence of heart failure, it is recommended that brain natriuretic peptides or BNP or NT-proBNP is measured. This is a marker of myocardial stretch and is quite reliable for ruling out the presence of heart failure if the value is within normal limits. If elevated, then imaging with echocardiogram is the next step so that ejection fraction and heart structure can be reviewed. Once the diagnosis of heart failure is made, therapeutic intervention must be planned. This is the 2021 recommended treatment protocol of the European Society of Cardiology for heart failure patients with reduced ejection fraction. As you can see, it is recommended that all patients with reduced ejection fraction should receive the 4 pillars of heart failure management, which are marked in green, namely ACE inhibitor or ARNI or angiotensin receptor neprilysin inhibitor, beta blocker, mineralocorticoid receptor antagonist or MRA, and sodium glucose cotransporter 2 or SGLT2 inhibitor. All 4 drug classes have evidence of significantly prolonging life among patients with HFrEF. Diuretics, also marked in green, are indicated if the patient manifests with signs of volume overload, such as edema or shortness of breath, or inability to lie down flat on bed. For patients with HFmrEF, or heart failure with mildly reduced ejection fraction, or EF of 41 to 49%, only 2 drug classes have received a class 1 indication, meaning clinical trials have shown that these drugs are associated with a significant improvement in the patient's prognosis. These 2 drug classes are diuretics and the SGLT2 inhibitors dapagliflozin and empagliflozin. As for symptomatic heart failure patients with preserved ejection fraction, only diuretics for fluid retention and SGLT2 inhibitors have been shown to have a positive impact on prognosis. It is comforting to know that all these drug modalities are available in the country, so there is no reason why heart failure cannot be treated early and optimally. For after all, the ultimate goal of therapy is to prolong the patient's life, ensure that the patient's quality of life is improved, and to cut down the expenses of recurrent hospitalizations due to acute decompensation and deterioration, which is usually a consequence of less than adequate heart failure management. Thus, proper and optimal treatment of heart failure should not be delayed for any reason. Now, let's go to our last topic, heart irregularities or cardiac arrhythmia. The heart is unique because it is the only organ in the body which has its own intrinsic beat. This is due to the presence of nodal cells which are capable of initiating cell stimulation and conduction fibers which propagate the stimulation to all heart muscles, resulting in an organized muscle contraction that is needed to move blood from the heart to the rest of the body. This is the conduction system or electrical connections of the heart. There are 2 major nodes in the heart, namely the sinoatrial or SA node and the atrioventricular or AV node. The SA node is the primary pacemaker of the body and it dictates the rate of heart contraction. The electrical stimulation will emanate from the SA node and will be transmitted by the conduction fibers to the AV node, after which it spreads to the right and left bundles of the left ventricle, resulting in a synchronized muscle depolarization, which then leads to a ventricular contraction. So, depolarization is the electrical event which triggers ventricular systole or contraction. So, how does this work? Let's go back to the basic cell membrane. The cell membrane is a semi-permeable membrane which allows it to choose which elements are allowed to pass through. Thus, the fluid inside the cell, or the intracellular fluid, contains more potassium ions, while the extracellular fluid have higher sodium and chloride ion levels. However, since potassium easily passes through the cell membrane, this results in a more negative charge inside the cell versus the extracellular fluid. These different ionic concentrations result to a charge across the membrane called the membrane potential, which is the ability of the cell membrane to be excited or polarized. For most muscle cells, an external stimulus, shown here by the red arrow, is needed to cause the change in membrane potential, which will in turn cause depolarization and subsequent muscle contraction. But the heart muscle is unique because it does not need an external stimulus to depolarize. Instead, the cells of the heart have a funny channel through which calcium, sodium, and potassium ions leak. Movements of these charged particles in and out of the cells cause a change in the electrical charge across the cell membrane, making the cell polarized or excited. These changes in the membrane potential allows the spontaneous firing or depolarization of the cells. The action potential of the sinus node on the right upper quadrant of this graphic looks different from the muscle action potential that we were looking at earlier. The small yellow arrows point out the fact that there is a spontaneous rise in the electrical charge of the membrane potential until it spontaneously fires and depolarizes. This is due to the movement of the sodium and calcium ions across the funny channel. Please note the difference in the shape of the action potentials of the SA and AV nodes in blue and orange compared to the muscle. The summation of all these electrical potentials is recorded on the surface as the PQRS complexes of the electrocardiogram or ECG. This is the basic unit complex of the ECG. Each complex should have a P wave, a QRS complex, a T wave, and in some you will also find the U wave. Each component reflects an activity that goes on in the heart. The P wave reflects atrial depolarization. The QRS complex reflects ventricular depolarization, while the ST segment and T wave and the U wave, when present, reflect ventricular repolarization. This is what a normal 12-lead ECG looks like. Each of the complexes should look narrow and slim, and the beats should be appearing at a regular rate. Arrhythmia simply refers to loss of regularity of the beats, and this is usually related to the formation of beats from areas other than the sinus node. There are two types of irregularities, classified according to where they originate. Supraventricular arrhythmia are beats which come from the AV node or higher, such as from the atrial region. These include atrial fibrillation and nodal rhythms. Ventricular arrhythmia, such as ventricular premature beats and ventricular fibrillation, come from below the AV node and the ventricles. The type of irregularity becomes important when choosing which drugs to prescribe to manage the irregularities. There are four major classes of antiarrhythmic drugs. Class 1 are the sodium channel blockers, Class 2 are the beta blockers, Class 3 are the potassium channel blockers, and Class 4 are the calcium channel blockers. As you can see, the three most important electrolytes in the maintenance of membrane potential, which are sodium, calcium, and potassium, are the primary targets, and they hit the action potential at different points in depolarization and repolarization. Treatment of heart irregularities are targeted primarily to control the disturbing manifestations, which include palpitations, chest pain, heart failure, and hypotension. Most important, though, proper management of irregular heartbeats can also prevent the occurrence of sudden cardiac death. The panel at the top shows beats coming in groups. Sometimes there will be about 10 fast beats, then it will suddenly slow down. This irregularly irregular rhythm is what is known as atrial fibrillation. The lower panel shows the beats coming rapidly, one after the other, with a sustained rate and narrow QRS complexes. This is known as atrial tachycardia. This tracing looks different from the one we just saw. You see that the QRS complex is wider and occurring at a rapid rate. This is ventricular tachycardia. As we mentioned earlier, it may be possible to still survive with atrial arrhythmia, but ventricular irregularities are a different story. Very often, when you see this happen, this condition will quickly deteriorate into an irregular rate with shorter and irregularly shaped QRS complexes. This is known as coarse ventricular fibrillation, and the patient will usually no longer have a palpable pulse at this point. This requires rapid intervention because this can progress to fine ventricular fibrillation, which is seen on the lowest panel, and eventual death. It is also possible to go from ventricular tachycardia to ventricular fibrillation and death. Therefore, it is very important for the clinician to learn to use antiarrhythmic drugs properly because they give the patient a chance to live longer. But the most important lesson to learn is that all these complications of heart irregularities, heart failure, and death are preventable, especially when the process is arrested very early in the cycle from the level of the risk factor. Early intervention can arrest the deterioration and progression towards death. The first step in prevention of significant heart disease is to manage hypertension and diabetes and dyslipidemia very early, stop smoking, and maintain a healthy lifestyle.